Good morning, everybody. So today we'll have an interesting debate on this controversial topic on the role of IV plus intraperitoneal chemo versus only IV in stage 3, optimally debulk stage 3 ovarian cancer. So Hemant will be speaking for and he will highlight the points in terms of favor of IV plus IP. So Hemant, you can start your presentation.
Yes, ma'am. Good morning, respected teachers and colleagues. My topic, I am speaking in favor of IV plus IP chemotherapy. So coming to the rationale for intraperitoneal chemotherapy in ovarian cancer, intraperitoneal spread is the most common and recognized characteristic of ovarian cancer. And this makes the disease an ideal candidate for IP drug delivery strategy. And it has a proposed pharmacokinetic advantage over systemic chemotherapy. The presence of peritoneal plasma barrier maintains high concentration gradient of cytotoxic drug between peritoneal cavity and plasma compartment. The absorption of intraperitoneal chemotherapy to systemic circulation depends on molecular weight and charge of the drug. So highly charged hydrophilic large molecules are more effectively sequestered in the peritoneal cavity, resulting in higher concentration intraperitoneally compared to systemic circulation. And this results in longer and more intense action of chemotherapy at the peritoneal surfaces where cancer emboli were entrapped. Cisplatin and paclitaxel were the most commonly used agents in the treatment of ovarian cancer. And these two drugs have peritoneal to plasma gradient ratios of 20:1 and 1000:1 respectively. So coming to the evidence for IV plus IP chemotherapy, this evidence came from three large randomized trials, that is GOG104, 114 and 172. Coming to GOG104, this trial compared intraperitoneal cisplatin plus IV cyclophosphamide versus IP cisplatin and IV cyclophosphamide. So participants were stage 3 disease with residual less than 2 centimeters and PS0 to 2. Interventions in this trial was in arm 1, IV cyclophosphamide plus IV cisplatin was given every 3 weeks for 6 cycles. And in arm 2, IV cyclophosphamide plus IP cisplatin 100 mg per meter square or given every 3 weeks for total of 6 cycles. And the primary outcome was the overall survival. And if we see the survival curve in this trial, it favors the intraperitoneal chemotherapy arm compared to IV chemotherapy. And the median OS was 49 months with intraperitoneal chemo compared to 41 months with IV chemotherapy. And this was significant. They did subset analysis in patients who have subset analysis as per the microscope, as per the residual disease after surgery. In patients who have microscopic disease, IP chemotherapy has more survival advantage compared to residual disease. And the median OS was 76 months in patients who have microscopic residual disease compared to 42 months for less than 0.5 centimeters and 32 months for 0.5 to 2 centimeters. So intraperitoneal chemotherapy favored more in patients who have microscopic residual disease. Coming to a second trial, GOG114. In this trial, stage 3 ovarian cancer patients who have optimal debulking surgery defined as residual disease less than 1 centimeter were randomized to IV chemotherapy arm consisting of paclitaxel 135 mg per meter square given over 24 hours infusion on day 1 plus cisplatin 75 mg per meter square IV on day 2 for a total of 6 cycles. And the IB chemotherapy arm, in the IB chemotherapy arm, initially they have given a high dose of carboplatin, that is AUC 9 for 2 cycles every 28 days. Then there was a 4 weeks gap. Then paclitaxel 135 mg per meter square was given over 24-hour infusion on day 1 plus plus cisplatin 100 mg per meter square intraperitoneally was given on day 2 for a total of 6 cycles. And the primary endpoint of this study was PFS and OS. from August 1992 until April 1995, a total of 523 patients were entered in the study, and 462 patients were eligible, and they were randomized to two arms. 227 patients to IV IV arm versus 235 patients to IP arm. So baseline characteristics were comparable in the two arms, and if we see residual disease status, almost 1/3 of patients have microscopic residual and 2/3 have gross residual disease in the both arms. So coming to the progression-free survival in this arm, PFS was significantly more in patients who received intraperitoneal chemotherapy compared to IV chemotherapy, and the median PFS was 22 months with IV chemotherapy versus 28 months with intraperitoneal chemotherapy, with hazard ratio of 0.78. And the overall survival was also significantly more in patients who received intraperitoneal chemotherapy. That was 52 months with IV versus 63 months with intraperitoneal chemotherapy, with hazard ratio of 0.81. Coming to the number of courses received, total 71% of the patients in the IP chemotherapy arm has completed entire treatment course, and 86% of the patients completed entire treatment course in IV arm. So coming to the adverse events in this trial, hematological and infectious complications were significantly more in patients who received intraperitoneal chemotherapy, and rest of the toxicities were comparable in both arms in this trial. Coming to GOG172, in this trial, stage 3 ovarian cancer who has optimal debulking surgery defined as residual disease less than 1 centimeter were randomized to IV arm consisting of paclitaxel 135 mg per meter square given over 24 hours infusion plus cisplatin 75 mg per meter square given at 21 days interval for 6 cycles, and the IP arm consisted of paclitaxel 135 mg per meter square given over 24 hours on day 1, cisplatin 100 mg per meter square intraperitoneally on day 2, and paclitaxel 60 mg per meter square intraperitoneally on day 8 for a total of 6 cycles. And they are stratified as per the gross residual disease and the planned second look laparotomy. In this trial, second look surgery was the patient choice. And the primary endpoint of this study was the PFS and OS. So coming to the characteristics, second look surgery, almost 49% of the patients selected for second look surgery after completion of the treatment. And in this trial also, 1/3 of patients have no gross residual disease and 2/3 have gross residual disease, like GOG114 trial. So 429 patients were enrolled in the study, and they were randomized to two arms, 215 in IV arm and 214 in the intraperitoneal arm. In this trial, if we see total 174 patients out of 215, that is 83% of the patients completed the entire planned 6 cycles in IV arm, and 86 of 205 patients, that is 42% of the patients completed entire 6 cycles in the IP arm. So coming to the progression-free survival, it was significantly more in patients who received intraperitoneal chemotherapy. That was 18 months in the IV arm compared to 23 months in the intraperitoneal arm, with hazard ratio of 0.8. And the overall survival was also significantly more in patients who received intraperitoneal chemotherapy. The median OS was 49.7 months in the IV arm versus 65 months in the intraperitoneal arm, with hazard ratio of 0.75. They did subset analysis as per the status of residual disease, and they found no significant difference whether patients have gross residual disease or no visible residual disease in terms of PFS and OS. And if we look at the second look, if we see second look surgery of 415 eligible patients, 49% of the registered patients have second look surgery, and the rate of complete pathological response was 41% in IV chemotherapy group versus 57% in intraperitoneal group. So coming to the adverse events, hematological infectious complications, catheter-related complications, and metabolic events were significantly more in patients who received intraperitoneal chemotherapy compared to IV. But if we look at the quality of life, there was no significant difference in the quality of life after 1 year of completion of treatment between the both arms. This is the retrospective analysis of Gog114 and 172 trials after a median follow-up of 10.7 years. And this showed that intraperitoneal chemotherapy has enhanced median OS from 51 months to 61.8 months. And they have also analyzed the probability of overall survival with the number of intraperitoneal chemotherapy cycles received. In patients who received entire 6 cycles of intraperitoneal chemotherapy, was benefited most compared to less number of cycles. So survival has increased with increasing number of intraperitoneal chemotherapy cycles received. And these are the hazard ratios for PFS and OS in different studies comparing IV versus IP chemotherapy. And these are in favor of PFS and OS both are in favor of intraperitoneal chemotherapy. And the hazard ratios were 0.77 with for PFS and 0.8 for OS. Coming to Gog252 trial, this was actually this compared the IV chemotherapy plus IP carboplatin and IP cisplatin. This trial was designed as superiority trial to show the superiority of the intraperitoneal chemotherapy over IV chemotherapy. The trial design was this trial has 3 arms: IV carboplatin, IP carboplatin, and IP cisplatin. In IV carboplatin arm, paclitaxel was given on day 1, day 8, and day 15, plus paclitaxel on day 1, day 8, and day 15, plus carboplatin AUC6 on day 1 every 21 days for 6 cycles. In IP carboplatin arm, paclitaxel 8 mg per meter square was given on day 1, day 8, and day 15, and carboplatin AUC6 was given as intraperitoneally every 21 days for 6 cycles. And in the IP arm, this regimen is more like Gog172 regimen, but with modified doses, consisting of paclitaxel 135 mg per meter square on day 1, given over 3-hour infusion, plus cisplatin 75 mg per meter square intraperitoneally on day 2, and paclitaxel 60 mg per meter square on day 8. Bevacizumab was added to all 3 groups. So if we see the progression-free survival, PFS was comparable in all 3 arms, and they did not show a benefit, extra benefit with IP chemotherapy, and median PFS was around 27 months in all the 3 arms, and the OS was also comparable with all the 3 arms. So they couldn't show the benefit of IP chemotherapy over the IV chemotherapy, but caveat of this study is the modification of cisplatin dose from 100 mg per meter square to 75 mg per meter square. In previous major trials with IV chemotherapy, they have used cisplatin 100 mg per meter square intraperitoneally, and in this trial they have come down to 75 mg per meter square. And the paclitaxel dose in previous trials was given as 24-hour infusion, and in this trial they are given over 3 hours instead of 24 hours. This might be the reason for compromised efficacy of intraperitoneal chemotherapy in this trial. In addition, the interaction between cisplatin and bevacizumab increased hypertension, and more participants discontinued bevacizumab and received fewer number of chemotherapy cycles in IP cisplatin arm. And in this trial, Gog252, 57% of the patients have no gross residual disease, as opposed to only 1/3 of patients in Gog114 and 172 trials. In those 2 trials, only 1/3, that is around 33% of the patients have no gross residual disease. And in this subset of patients, median OS was 35 months with intraperitoneal cisplatin, and the median OS was not reached with IP cisplatin arm. This is the retrospective review of Gog114 and 172 trials. And in this trial, prognostic factors were analyzed in patients who received intraperitoneal chemotherapy. In this trial, in patients who has microscopic residual disease, PFS was significantly more, that was 43.2 months in patients who have microscopic disease, and the median OS was 110 months in patients who have microscopic disease. This was significantly more when compared to patients who have residual disease, gross residual disease. And median PFS and OS when compared to IV chemotherapy arm, they were 33 months and 82 months respectively. So to conclude, IV plus IP chemotherapy resulted in significant improvement in PFS and OS compared to IV chemotherapy alone, and it should be the standard of care in patients in stage 3 optimally debulked epithelial ovarian cancer. Thank you.
Okay, so Hemant, can you please summarize the important points in favor of giving an IP plus IV regimen?
Yes, ma'am. IP plus IV regimen has significantly improved PFS and OS compared to IV chemotherapy, and this benefit is significantly more in patients who have microscopic residual disease compared to gross residual disease. And the definition of optimal debulking surgery also should be redefined. Earlier in these trials were conducted around 2005. At that time, the definition of optimal debulking surgery was the residual disease less than 1 centimeter, and it should be defined. And IP chemotherapy favors more in patients who have microscopic residual disease, and this should be considered in the subset of population.
Yeah, so I agree with you. I would just like to say that we have 3 large randomized trials, and then we have a meta-analysis, and all of them have shown a survival reaching up to 110 months. So the survival has now reached 100 months. But only thing is that we have to be very careful while selecting our choice of patients for whom we want and IP plus IV regimen to be given. So they should be young, fit, and most important is to see the R0 status. They should be optimally debulked. Because when we saw the comparison of survival between patients who have undergone a complete debulking surgery versus the ones who had macroscopic disease left behind, the IP plus IV regimen only caused reduction in survival and increase in toxicities. So I invite Seema ma'am to give her comments.
I think, Sushmita, we should first ask Lakshma to present and then we'll conclude in the end.
Yes, ma'am.
Good morning, everyone. Today I'll be talking in favor of IV chemotherapy after optimal cytoreduction in high-grade. Drugs typically given in IP therapy are taken up by passive diffusion, so generally large tumors are unlikely to benefit. Preclinical studies suggested that cisplatin is capable of penetrating small volume of tumors of 1 to 3 millimeters only. The drug clearance from the peritoneal cavity is significantly lower from the vascular compartment, resulting in prolonged duration of drug exposure, which can lead to increased toxicities. Most centers calculate the drug dosage according to the estimated body surface area, but it has been demonstrated that the actual peritoneal surface area and estimated body surface area correlation is generally flawed, and it is generally gender dependent. So first, NCI in 2006 has approved Ib chemotherapy after the Gog172 trial. So first, I would like to start with this trial. It's a phase 3 trial. Compared IV paclitaxel plus cisplatin with IV paclitaxel plus IP cisplatin and paclitaxel in patients with stage 3 ovarian carcinoma. Patients with stage 3 ovarian carcinoma or primary peritoneal carcinoma with no residual mass greater than 1 centimeter were included in the study. The arm 1, that is the IV group, received IV paclitaxel 135 mg per meter square over 24 hours, followed by IV cisplatin 75 mg per meter square on day 2. Arm 2, IV paclitaxel was given 135 mg per meter square over 24 hours on day 1, followed by IP cisplatin 100 mg per meter square on day 2 and IP paclitaxel 60 mg per meter square on day 8. Treatments were administered every 3 weeks for 6 months. So I would like to everyone to note that in arm 1, cisplatin was given 75 mg per meter square, that is in the IV group, whereas in IP group cisplatin was given 100 mg per meter square, and in arm 2, IP group received 60 mg per meter square on day 8. Uh, 384 patients. The primary study endpoints: progression-free survival and overall survival. Median duration of follow-up was 48.2 months in the IV group and 52.6 months in the IP group. Median PFS, as Sir has mentioned, was 18.3 months in the IV group and 23.8 months in the IP therapy group. So, if we see, out of the 429 patients who were randomly assigned, 215 patients were assigned to the IV group and 214 to the IP group. Of this, in 210 patients who were eligible in the IV group, 174 patients have received the assigned IV therapy. The other 189 who were not tolerating cisplatin, included 174 plus 15 patients who were not tolerating cisplatin and had to be given carboplatin. Whereas coming to the IP group, if you see, out of 205 patients, only 86 patients were able to receive complete 6 cycles. Overall, 170 patients have received complete 6 cycles. Of them, 2 patients received IP plus IV, because as they were not tolerating the IP therapy, they had to switch over to the IV therapy group. So if you see the adverse events that were noted in this trial, all the toxicities, leukopenia, thrombocytopenia, and other hematological toxicities, gastrointestinal events, renal failure, neurological events, fever, infections, any metabolic events, electrolyte disturbances, pain, all the adverse events were more in the IP group. This study has higher dose of cisplatin in the IV-IP arm compared with the IV, which could be the reason for survival benefit. Only 42% of the patients were able to complete all 6 cycles of IP therapy. Discontinuation rate of IP therapy is high because of complications associated with IP catheter, toxicities associated with IP administration, and toxicities associated with chemotherapy itself. Patients receiving IP therapy reported worse quality of life before cycle 4 and 3 to 6 weeks after treatment. As Sir has mentioned, after 12 months follow-up, they had comparable, but it is to be noted that paresthesia stayed to more percent in patients with IP therapy arm, even at the end of 1 year. This GOG252. This is a open-label randomized phase 3 trial. It included newly diagnosed advanced epithelial, ovarian, fallopian, and primary peritoneal cancer included in the study. It is the largest randomized trial ever performed using IP therapy. In this, patients were randomly assigned to, as it was previously mentioned, 3 arms: IV carboplatin, IP carboplatin, and IP cisplatin. All the 3 arms also received bevacizumab every 3 weekly. So, in overall intention to treat population of 1,560 patients, 73% of them experienced progression. Compared with the IV carboplatin, the hazard of progression or death was 7.5% lower in the IP carboplatin. The hazard ratio is 0.9, confidence interval ranging from 0.8 to 1.07, which is very borderline. Okay, compared with the IV carboplatin, the hazard of first progression or death was 2.3% lower for the IP cisplatin. Here also the hazard ratio is 0.977 with 95% confidence interval ranging from 0.847 to 1.1. So there was no statistically significant difference in PFS between the IV regimen and either of the IP regimens. So PFS of patients with optimally resected, here we have taken optimally resected stage 2, stage 3 cancers with 1 centimeter or less residual disease per surgeon. In 1,380 participants evaluated, 71% of them had 26.9 months of IV in the IV group and IV carboplatin group, 28%, 28.7 months in the IV carboplatin arm, and 27.8 months in the IP cisplatin arm. All three, if you see the hazard ratios of IP carboplatin was 0.9, confidence interval ranging from 0.7 to 1.07. And for the IP cisplatin arm, hazard ratio 0.96, 95% confidence interval ranging from 0.8 to 1.1. Thus, there was no statistically significant difference between the IV and either of the IP regimens. But if we see the adverse events, grade 3 and grade 4 toxicities were significantly higher in the IP groups. The benefit of IP administration of chemotherapy was not evident in this large randomized clinical trial. The toxicity profile support the decision to select IV regimen with no evidence that this compromises PFS or OS. It is noted that if bevacizumab is administered, the survival advantage to use IP chemotherapy seems to be negated. Also, use of weekly paclitaxel compared to the 3-weekly schedule was found to negate the survival advantage associated with IP therapy, which was previously proven in Japanese GOG trial. Dose-dense paclitaxel was found to be superior compared to the 3-weekly. The OS for stage 3 optimally debulk patients in all arms of GOG 252 compares favorably with the IV-IP arm of GOG 172. This is GOG 114 trial. Here, patients were randomized to receive either IV paclitaxel 135 mg per meter square over 24 hours, followed by IV cisplatin 75 mg per meter square every 3 weeks for 6 courses. Or IV carboplatin was given at AUC 9 every 28 days for 2 courses, followed by IV paclitaxel over 24 hours, followed by IP cisplatin 100 mg per meter square every 3 weeks for 6 courses. Here also it is to be noted that cisplatin IV was given 75 mg per meter square in the IV arm, and in the IP arm it was given 100 mg per meter square. And initially it was started with IV carboplatin was given at AUC 9 for 2 courses. Even then, there was borderline improvement in the overall survival associated with this regimen. But grade 3 or 4 adverse events were more common with the experimental arm. Here, these are the grade 3 and grade 4 toxicities that are associated. So this is the GOG 104 trial, which was the first trial that was conducted in 1986 to 1992. Arm 1 included IV cyclophosphamide, IV cisplatin. Arm 2, IV cyclophosphamide with IV cisplatin were administered at 3-week intervals. So they had bed survival advantage was present on IP arm, and the the toxicities were also comparable in this trial, but it is to be noted that it was later proven that paclitaxel is more is associated with improved PFS compared to cyclophosphamide, and now use of cyclophosphamide as first line therapy is obsolete now. Here, in arm 1 cisplatin, 75 mg per meter square with cyclophosphamide was used, and arm 2 cisplatin with paclitaxel. Paclitaxel was given at 135 mg per meter square over a period of 24 hours. PFS was significantly longer in the cisplatin paclitaxel group than in the cisplatin cyclophosphamide group. So this is another trial. Here, all the toxicities were previously covered in the other trials, but here I would like to make a special mention to the last, that is the disease recurrences. Here, it is to be noted that distant disease recurrences were more common with the use of IP therapy, suggesting that the systemic control of the disease is being compromised with IP chemotherapy. So here, if you see the toxicities associated in among different trials, we can see all the toxicities are in the favor of IV chemotherapy. This is a comparative study comparing Gog172 and different other trials. This includes pain, grade 3, grade 4, infection, grade 3, grade 4, and gastrointestinal side effects and fever. All the adverse effects were found to be more on the IP therapy across different trials. Also, if we take the percent completion rate of IP chemotherapy, first, if we see the Gog172, based on which IP chemotherapy was approved, here completion rate was only 42%. And if you see all other trials, the IP regimen was associated with lower completion rate. So this is about the what is our experience in our institute with IP chemotherapy. It was a prospective evaluation of the feasibility of IP chemotherapy in patients with advanced epithelial ovarian cancers after optimal primary or interval cytoreduction was done. 11 patients were included in the study, of which 9 patients had interval surgery after NACT and 2 had primary surgery. Regimen used was paclitaxel 135 mg per meter square IV over 24 hours on day 1, cisplatin 100 mg per meter square in 2 liters of normal saline IP on day 2, and paclitaxel 60 mg per meter square in 2 liters of NS IP infusion on day 8. The total number of IP chemotherapy cycles planned in 11 patients was 36, of which 30 only could be given. The day 8 could not be given in 11 cycles, and the dose reduction was more than 25% was required in 2 cycles due to significant toxicity. Toxicities. These are the different toxicities that were noted. Vomiting, these are grade 3, grade 4 toxicities in 43.3%, abdominal pain in 33.3%, dyslipidemia 26.7%, neutropenia 40%, fetal neutropenia in 10% of the patients, and port site extravasation was seen in 1 patient, that is 3.3%. So this observation was a bit disappointing. So I think it was not taken further. So we have in this current era of precision medicine, for the questionable survival benefit that is associated with the IP chemotherapy, it can be actually achieved through the other means. It's like we now have the newer drugs like PARP inhibitors, and there is increasing evidence which support use of PARP inhibitors as maintenance therapy after the first line therapy, like after surgery and completing of the chemotherapy with taxanes and platins. We can use PARP inhibitors as maintenance therapy. It has been proven in different trials. Solo 1 trial, maintenance therapy with olaparib provided 70% lower risk of disease progression or death with olaparib than with placebo. In Prima trial, it was enrolled subset of patients with stage 3-4 high-grade serous and endometrioid ovarian cancer with response to chemotherapy, which was regardless of BRCA status. Median PFS was 8.2 months versus 13.8 months. In Paola trial, patients with stage 3-4 high-grade serous ovarian carcinoma regardless of BRCA status used bevacizumab and bevacizumab plus olaparib. The median PFS was more in patients who used olaparib with bevacizumab. So I would like to conclude saying that IP chemotherapy is applicable only to patients with advanced disease who had optimal debulking, have less than 1 centimeters of residual disease. It can be used only in centers which have experience with IP chemotherapy. Recent report share, though it was approved in 2006, even in the 6 NCCN cancer centers, the use is only 47%. Then we can assume in Indian scenario how we can manage it. Adhesion formation after debulking surgery prevents equal distribution of drugs administered intraperitoneally. Studies suggest that IV chemotherapy regimens are associated with more distant relapses, suggesting systemic control of diseases being compromised. Optimal IP versus IV chemotherapy regimen is yet to be defined. IP route needs to be explored with better tolerated schedules, doses, and agents. There are no studies reported of IP chemotherapy in women with stage 4 ovarian cancer who underwent optimal cytoreduction surgery. Recommendations for the precise IP chemotherapy regimens are not possible because the IP chemotherapy regimens published were modified based on patient tolerance individually. The increased toxicities associated with IP chemotherapy warrant careful monitoring, treatment modifications, and use of contemporary supportive care measures for newer drugs with fewer toxicities. Thank you.
Thank you, Lakshma. Hemant, would you like to speak for 1 minute against Lakshma now, because he has made his points very clear that IP chemotherapy is likely to have significant toxicity and there are other options available.
Yes, ma'am. In Gog172 trial, even though there are less completion rates, PFS was and OS were significantly more significant in favor of intraperitoneal chemotherapy. And if you see the adverse effects, even though more adverse effects in the IP chemotherapy, they were manageable. And if you see the deaths related to treatment, they were similar in IV and IP both arms, with 4 treatment-related deaths in IV arm and 5 treatment-related deaths in IP arm. So even with less completion rates, IP chemotherapy has significant PFS and OS benefit.
So you still stand on your point that IP chemotherapy should be given?
Yes. And in Gog252 trial, as I already mentioned, in IP cisplatinum, suboptimal regimen was used. That might be the reason for non-superiority of IP regimen over IV regimen. And addition of bevacizumab in patients who have microscopic residual disease is also questionable.
Why it is questionable?
Ma'am, if we look at the comparison rates, if we see in subset of patients who have microscopic residual disease, in Gog252 arm, it was around median PFS was around 34 months and median OS was not reached. And if we compare this with the analysis done by, after a median follow-up of 10 years, retrospective analysis combining Gog114 and 172 trials, and they have showed median PFS of 43 months and median OS of 110 months without bevacizumab.
But bevacizumab has shown OS advantage in Gog trial. In ICON 7 trial. Those who had microscopic, those who had residual disease and stage 4, there was an OS benefit with the use of bevacizumab. So we can't say that bevacizumab has no benefit in ovarian cancer. And there is one question in the chat box. Where do you place HIPEC?
HIPEC will be placed in patients who have in patients who have optimal debulking surgery in stage 3-4 ovarian cancers.
So which one
And
would you
this
place for HIPEC or intraperitoneal chemotherapy?
This I cannot.
Okay, so just stop sharing.
Yes. Lakshma, stop sharing.
Dr. Kumar, whom do you think is the winner? Hello, am I audible?
Yes, ma'am.
Okay, just to summarize the takeaways from today's debate. So we have seen that we have 3 randomized trials that have shown that IP chemotherapy is better, and 1 randomized trial which has shown that IP chemotherapy has no benefit over the IV chemotherapy. So if we compare head to head between GOG 172 and 252, the baseline characteristics that affect the outcome of an ovarian cancer is the initial stage and the optimal cytoreduction. In GOG 172, all 100% patients were stage 3, but in 252, there were stage 4 also included. The optimal cytoreduction was significantly higher in the GOG 252 compared to 172. If we look at the dose intensity of the chemotherapy that both Hemant and Lakshma have spoken about, but particularly the dose intensity of intraperitoneal chemotherapy was better in the GOG 172, where IP paclitaxel was also given on day 8. This was not the case with GOG 252, where only IP was given on day 2 and that too cisplatin. If we look at the molecule per se, the cisplatin as well as the paclitaxel is a higher, larger molecule and it is non-water soluble. Cisplatin is a smaller molecule and it is water soluble. So systemic absorption is higher with cisplatin, and the concentration that is achieved with the use of cisplatin intraperitoneally is 20-fold higher than the systemic one. But in case of paclitaxel, the concentration which is achieved is 1000-fold higher than the IV concentration. So probably it might be possible that the intraperitoneal use of paclitaxel in 172 made all the difference rather than cisplatin alone. Moreover, there were differences in the way in which paclitaxel was administered. It was given over 24 hours in 172 and over 3 hours in 252. But I don't think that is the main reason that made the difference. It is the dose intensity of the intraperitoneal chemotherapy that made the difference between the outcome of these 2 trials. So, and the baseline characteristics were not comparable. So we can't really say that GOG 252 was a true negative trial. Okay. And if we talk about bevacizumab, we have to be careful with the fact that bevacizumab was also used as a maintenance in GOG 252 and it was given for 1 year, whereas there was no maintenance therapy in the GOG 172. Probably the use of bevacizumab might have negated the effect of intraperitoneal chemotherapy because that have altered the pharmacokinetics as well as pharmacodynamics of the intraperitoneal drug that were instilled along with the intravenous bevacizumab. So to answer this question of what is the, sorry, I'm not able to change the slides. Yeah, so to answer the question of what is the role of bevacizumab per se in the intraperitoneal chemotherapy, this is the IPOC trial which is currently ongoing. And this trial has randomized patient between IV carbo versus IP carbo, and this trial is without bevacizumab. So probably this trial will give us the answer, what is the role of bevacizumab in these patients per se. Coming to the HIPEC is basically, it is done at the time of interval debulking surgery, and this is done when patients who have achieved optimal cytoreduction, they were randomized between HIPEC versus no HIPEC. And here, this basically the whole idea of starting HIPEC was that at the time of surgery, it will be done so that the catheter-related complications that are seen with intraperitoneal chemotherapy is not there. But this is the only single trial which is a phase 3 trial published in 2018. And if you look at the number of total number of patients who were randomized, that was small. And as the follow-up increases, the number at risk by 5 years were hardly anything, 12 and 22. So further trials are ongoing, and the role of IPEC will slowly come into picture, and then we will be able to identify in whom we should be doing it. But in today's era, the outcome of ovarian cancer has improved, and there is significant advancement in the understanding of the molecular biology of this disease. And if we look at this SOLO-1 trial, the median PFS in olaparibam is 56 months compared to the 13 months, which is huge difference. So probably the better understanding of the molecular biology of the disease and use of targeted therapy, we may not need this intraperitoneal therapy as well as the HIPEC. So why IP is not favored? Because of high toxicity, inconvenience which is caused to the patient. There are many catheter-related complications. Intraperitoneal chemotherapy requires a lot of resource use, and it is associated with high cost. And in fact, there's a cost-effective analysis which has shown that IP chemotherapy is not cost-effective. Optimal IP chemotherapy regimen, still we don't know. We do not have an ideal regimen that will give a balance between efficacy as well as the toxicity. And there are many flaws in the clinical trial design of both the positive trial as well as the negative trial. So if we have to select a patient for IP chemotherapy, it is not been taken up in majority of the center. If you have to select, it has to be young patient, stage 3 patient who is optimally cytoreduced. There is also few studies which looked at this is a post-hoc analysis where they try to look at the BRCA status and the outcome with the IP therapy. And it has been seen that patients who are BRCA mutated, they gain much benefit with IP therapy. But this is also true that patients who are BRCA mutated, they will get more benefit with IV chemotherapy as well. So this is what in the end about the place of IP chemotherapy in present era. If there are any questions, I'm happy to take that. So dose dense PECLI. So Lingaras, there is one Japanese study which have shown that paclitaxel when given at weekly interval followed by and 3 weekly carboplatin, it has shown a OS benefit. But when the similar trial was done in US, it was GOG262 trial, it did not find any benefit with the use of weekly PECLI compared to the 3 weekly paclitaxel. But there is a counter argument in this trial is that in the US trial, bevacizumab was also used. So there are some suggestions that probably if we are using bevacizumab, then it negates the benefit of weekly paclitaxel. Do you have any more questions? If none, then I would request Dr. Kumar to come.